is very pertinent, palliative care in public health crisis. And the person I thought in terms of who we would want to celebrate this event really is Professor Bee Wee from the UK. She is the National Clinical Director for End-of-Life Care and in the National Health Service. In this role, she provides strategic leadership for palliative and end-of-life care across England. She co-authors the ambitious partnership for palliative and end-of-life care with 34 national partners. She's been awarded numerous awards, a Presidential Medal by the European Society of Person-Centered Healthcare. She has an honorary doctorate of science from Oxford Brookes University and a CBE in the year 2020 for services for palliative and end-of-life care. No doubt if she was in Malaysia, she would be a Dato or Tan Sri. But unfortunately, you're too far away at the moment. Even though our national strategy in Malaysia was put together really in 2019, and in the introduction, there's only just a brief aspects of what was happening in Malaysia. Bee Wee was very central in the development of palliative care here. In the early years of Hospis Malaysia, she and her then colleague and now partner, Dr. Richard Hillier, came over for 3 years to help us do workshops and give talks, mainly in the Klang Valley, to talk really about palliative care and helped us gain a foothold within the Malaysian palliative care scenario. And I think that was a major help in us developing Hospis palliative care within Hospis Malaysia. And even throughout the years, I think only recently, BU came to talk to our Ministry of Health just before we develop our national strategy to really tell us a little bit about how the UK approach palliative care within the NHS. So I think that it's been really wonderful to have you a part of the Hospis Malaysia family over the years. And it's quite apt to have you here again after 30 years. How it's wonderfully young of having you there. So really, perhaps I think we have got quite a lot of people in now. So maybe we will start. I would really advise everyone to potentially mute their mics for now. After the talk, there'll be ample opportunities for questions and answers. I have quite a celebrated list of attendees here, so we would certainly welcome your thoughts and opinion to what Bee will present to us. So really, I think it's over to you, Bee.
Thank you, Adnan, and thank you for that generous introduction and for all of you for gathering this evening. I suppose the bit that I'm most proud of in joining you today is that I'm a Penang girl. So I know that was a long time ago since I left Penang, but that never leaves you. So that's the first thing to say. I am going to now try and share my slides. Lovely, thank you very much. So I will go ahead to the next slide, please. Focus. So I thought maybe just to remind people that, for many years now, there's been discussion about the role of a public health approach to palliative care, and that concept of a public health approach to palliative care has been around for quite a long time. But of course, with the pandemic, palliative care just got thrown into center stage of public health. And certainly the UK experience has been palliative care has played a key role alongside critical care, respiratory care and emergency services. And I thought that's what we would focus on today. I will share with you my experience from the UK, but I'm really conscious that is the experience from, in fact, one part of UK, particularly England. I'll share that with you, and I'm able to do that because I've got that very personal experience. But I would really love to hear the experience from Malaysia and from other countries as well who are on the call when we come into the Q&A section. That would be really good, because I think we all have very individual experiences and we can all learn from each other. I will then share some thoughts around the learning and the consequences, again from my own experience, and a bit about the wider implications then for palliative care policy and practice going ahead. So, the concept of a public health approach to palliative care. May I have the next slide, please? So way back, in fact, the slide I'm just about to show has got quotes from Jan Sternswald, who many of you will know from 2007, but in fact his interest has been for a very long time already. And he talks about how a public health strategy for palliative care offers the best approach for translating new knowledge and skills into evidence-based, cost-effective interventions that can reach everyone in the population. But that for them to be effective, they must be incorporated by governments and they must be owned by the community. So it needs to be a whole system kind of approach. And that this strategy will be most effective if it involves the society through collective and social action. So he's really talking about a social movement for public health strategy. And he published, again, this next slide, please, this kind of umbrella approach to public health, thinking about you need to have the policy, and underneath the policy, you need to have three things. You need to have education, you need to have drugs being available, and you need to have implementation. And that they are framed by both the situation that you're in and the outcomes that you're in. So this is thinking about public health from a whole nation perspective for palliative and end-of-life care. So the World Health Organization then translated this and elaborated on this further by looking at what does that mean. So in terms of policy, it means a national health plan. And where I work in the UK, we have a National Health Service, so palliative care needs to be part of that National Health Service. It needs to have policies and it needs to be regulated, which it is for palliative and end-of-life care in England. It also needs to have funding and service delivery models that supports that, and it needs to have essential medicine. So all of that has to be part of policy and how that happens. And then we have to have drugs being available, and we have to have drugs really, it doesn't say so there, but it needs to be affordable drugs and accessible drugs. And then on the other side, you have the education of the professionals, of the public, of the families, of the patients. So all of that around education. And then in order to implement that, you need people. And what it doesn't say there is, I think you need leadership, you need trained staff, you need to have committed staff, and you need to have the kind of infrastructure that allows the implementation of a public health approach to palliative care. So that is one approach, and the WHO approach is very much thinking around a public health strategy, which of course is the role of a World Health Organization. Then in more recent years, there's been more talk of a more health promotion type of approach. Next slide, please, where it talks about social empowerment through things like compassionate communities, where the whole community changes, and things like, transport and housing, and so the wider community, in order to be able to manage that compassionate community. It talks about assets in the community, particularly voluntary access and volunteers mobilization. And of course, Malaysia is a very good example of a combination of all of those things. And in order to achieve this health promotion approach, we need to be able to influence society's perceptions of what is going on, of the importance of palliative care, and how much of a societal responsibility palliative care is. And you can only achieve this by doing lots of public awareness and education. So that's a health promotion approach, not dissimilar to health promotion in other areas of health. Next slide, please. And then there is a population-based approach where you look at the entire population and you look at how can you reach everybody in the population who needs palliative care. And this is where I think there is often a tension where for a country, for a system, for a healthcare system, for an organization, because what you're trying to do is to deliver gold standard care to the individual, but you may have to lower that gold standard in order to put your resources into reaching everybody. So is it better that everybody gets a bronze standard care, or is it better that a few people get gold standard care? And that's the tension that goes on in a population-based approach. So that's, and I'm sure there'll be people in the audience who are far more knowledgeable than I am about public health and about the whole public health approach to palliative care, and perhaps that's something too that can come out in our discussion. But one of the things I'm quite pleased about in England, and I'll have the next slide please, is that we do, I think, have an integrated approach. We could do better, but we do have an integrated approach in the form of our ambitions for palliative and end-of-life care. And some of you will have heard me speak about this before, so apologies if you have. But the important thing about the ambitions for palliative and end-of-life care is that it is a national framework. It's not a national strategy, it's a national framework, which then allows local areas to act on it. And what we're doing is, what we've done is build a number of outcomes, which I'll come to in a minute, but the number of outcomes, the building blocks that's needed for the outcomes, the foundations that are needed for the outcomes. And we're saying to all our colleagues and all the people and all society, you all have a part to play in this, you need to get on with it. This ambitions, unlike previous strategies, which was developed by the Department of Health or the Ministry of Health, the ambitions was actually developed across by 27 national organizations in 1995. We have just refreshed it. As you can see, this one is dated 2021 to 2026. We have just republished it as a second edition, and we now have 34 national organizations that have stayed together as a partnership to drive this forward. So it's very much owned, and I would say this is very much a public health approach because everybody owns that. And within it, next slide please, we have 6 ambitions. We have, first of all, the vision on the right-hand side, which says I can make the last stage of my life as good as possible because everyone works together confidently, honestly, and consistently to help me and the people who are important to me, including my carers. So it's very much spoken from the perspective of the person who needs palliative care. And in order to achieve that joint vision, we need 6 ambitions in particular. And those 6 ambitions are the person being seen as an individual, so very person-centered care, and person could also mean the carer, the bereaved person, but the person being seen as, each person being seen as an individual within that, each person getting fair access to care. So this is where equity comes in, and making sure that everybody gets fair access to care regardless of their condition, their diagnosis, their living circumstances, their level of social deprivation, all of that, that they get fair access to care. Sorry, can I go back to the previous slide, please? May I have the previous slide, please? So the third ambition is about comfort and well-being being maximised. So that is an important aspect of palliative care, and that brings me back to some of the drug availability that Jan Sternswal and Catherine Foley were talking about. But it's also about not just physical comfort and well-being, but psychological, emotional, spiritual comfort and well-being being really important. And part of that, for example, is being able to recognise the distress that needs to be addressed. The fourth ambition is about care being coordinated. This is a particular issue that we see in England, where there are many services and many people involved, which is great on one level, but can also mean that it gets a bit chaotic and uncoordinated for the person. So care being coordinated is really important, especially across organizational boundaries. So when somebody goes from home into hospital, when they go home from hospital, back home again, all of those things being coordinated is really important. The fifth ambition is about staff being prepared to care, not just in terms of education and training and skills, important that it is, but actually also in terms of their behaviors, their attitudes, their emotional resilience to be prepared to care. And that requires their employers to make sure that those conditions enable staff to care. And the last ambition is the one that's most pertinent to today's talk, which is each community is prepared to help. And that was a recognition that palliative care and the delivery of palliative care has got to be a whole society approach. Next slide, please. So for each ambition, we have a statement that describes the ambition, and I'm only going to show you the one for that last ambition. So in each community is prepared to help. From the person's perspective, the patient's perspective, I live in a community where everybody recognizes that we all have a role to play in supporting each other in times of crisis and loss. People are ready, willing and confident to have conversations about living and dying well and to support each other in emotional and practical ways. And I think you will all agree with me that that first sentence particularly has been so topical during COVID, not just for people affected by COVID, but also for people who have palliative care needs at a time when attention is distracted from them and resources move to supporting people with COVID. So it's really important. And now, of course, as COVID settles down a little bit, the whole impact, the long-term impact, long COVID bereavement, just the whole societal impact of having restrictions, not being able to meet, all of those things is where we actually do need to support each other more than ever. For each ambition, we then identified a set of building blocks. Next slide, please. And for each community is prepared to help, we had identified 4 building blocks in particular. So one is about the community being both compassionate and resilient, and this is where the public health approaches comes in. A second one is around improving public awareness about palliative care and what we're trying to achieve here and the difficulties that people face. Then very practically, some of the practical support that's needed, and also the role of volunteers in each community is prepared to help. So I think this 6th ambition is particularly embedded in the work that we do in the UK anyway, prior to COVID. So then COVID came along. Next slide, please. And as I've already mentioned, we have people who have palliative care needs as a result of COVID. We have people with palliative care needs who contract COVID, and we have people who don't have COVID, never contracted COVID, but who have palliative care needs. So there's a whole variety of needs that we have to pay attention to for people with palliative care. But at the height of the pandemic, when it first hit, I think we were just all running in all directions. Next slide, please. The next few slides are really more generic about COVID, demonstrating some of the data that we use to look at the different peak times that we all hit. So the pink line is Malaysia, is UK, and the green line is Malaysia. And as you can see, we had in the UK, we had a particularly difficult time in January. We have just been through really another kind of semi-peak, but we are still all struggling with that. Next slide, please. This was an interesting one. You won't be able to see the detail here, but it's one that you might, if you're interested in responses, you might want to look at this in more detail. The website is down there. It's a website called Our World in Data, which has some really interesting looks at things like, so this looks at how stringent governments were at different times and the number of people with COVID at different times. But you can see how uniform it was really on the left-hand side, which was in March 2020, where there was a big response, but also big markers there. And then on the other side of the thing, where you can see a lot more scattering, even within countries, of changes in the stringency of the response. Next slide, please. Now, I don't know about Malaysia, but certainly in the UK, there was a lot of conversation about what's safe to do, what's not safe to do, what were high-risk activities, what were low-risk activities. And this was just an amusing slide, which I thought you might find interesting, from a source called informationisbeautiful.net, which looked at risk factors and what were low risk. And obviously the low risk ones tended to be outdoor ones, and the high risk one tended to be crowds indoors, often with noise and shouting. So you can see that difference. And of course, in the UK, in the first wave of the pandemic, we had a very, very nice summer where people could be outdoors a lot more. The second wave in January is not a good time in the UK at all. And people did have a miserable time because you were confined indoors. So that whole outdoor situation was hard to take place. Next slide, please. The other thing that was interesting was some, I think researchers had a wonderful time during that period. Not the ones who were running trials because they had to stop, but a lot of the ones that were looking at data, looking at understanding behaviors and so on. This was one that actually looked at the adherence to high cost sensitizing behaviors versus low cost habituating behaviors. So what do we mean by that? And they looked at a lot of different countries, first of all, for data, and they also looked at mobile phone data to demonstrate some of the distancing behaviors. So the graph on the left-hand side is actually about physical distancing using masks, okay? Sorry, no, physical distancing in terms of social distancing. And it's the adherence that you're looking at there. So the avoidance of going out or avoidance of gatherings, when the governments brought in strict measures, the adherence was good, and then over time went down, and then gradually started to come back up again. These are considered to be more high cost behaviors because there's a social cost to it, to not going out, to not meeting people, to not being able to socialize. On the other hand, on the right hand side, there was a change in the mask wearing behavior where the adherence actually kept going up. And these were considered low cost behaviors that became more habitual and therefore easier to adhere to. Next slide, please. And again, this was a slide that looks at residential versus retail and recreation. I'm not going to spend time on this, but you may want to ponder over this in due course when you see the slides. Next slide, please. One of the things that became very obvious and we became very conscious of in England, but I don't think we were the only ones. I think this was true in many, many countries, was actually the whole issue about multimorbidity and how multiple conditions increases risk in relation to COVID, and particularly in deaths and hospitalizations, so in serious illnesses. And what the picture on the left demonstrates to you some old data that we've got in England, but I think that is still true, where if you are poorer, you are more likely to have multiple conditions at least 10 years sooner than people in the highest socioeconomic group. So that demonstrates to us that you've got a multiple factor of multimorbidity and social deprivation that then affects how you're affected by COVID. Next slide, please. So we can see that this slide. Could I ask whoever it is to put themselves on?
You are muted. Sorry, Professor, you're muted. Can you unmute your mic?
Oh, yes, thank you.
Sorry for the technical.
That's no problem. No problem at all. I think this slide is fairly self-explanatory anyway, so I will move on to the next slide, please. So I'm going to talk now about the experience in the UK. Oh, sorry, the previous slide, please. Thank you. I'm going to talk about the experience in the UK. As Ednin said to you at the beginning, my role is as National Clinical Director for Palliative and End-of-Life Care for England. So that's my national role. When the pandemic hit, I also had a local role of being both consultant in palliative medicine and also the head of my department locally here in Oxford. So it was a very surreal time because on the one hand, I was working at the national level, trying to help and put things in place across a national level. And then at the same time, you know, walking down to the ward and dealing with the issues here locally in terms of staff safety, infection control, changing our physical environment, and all of those things which many of you will be very familiar with on the call. But I'm going to talk primarily about my experience as a National Clinical Director. So the first thing is about recognizing the role of end-of-life care. We were lucky in England. Now, I know that some of the published evidence states that end-of-life care or palliative care was ignored during the pandemic. Actually, in England, it wasn't. It was recognized from the beginning. Actually, even before the COVID struck, we were asked to participate in pandemic planning for influenza. And then during the, when the pandemic was just starting off at this end, we would call it kind of March that it hit England particularly, but actually I remember a call that I got in the middle of February to say, please can you put together some plans for palliative care in case this is worse, this gets worse. So we put together some plans for the pandemic, really highlighting things like medicine supply, workforce, carers, availability, and so on. Then there was a National Incident Response Board that was formed. So this was a board that was formed for the whole of the National Health Service in England. And the National Incident Response Board had the responsibility of coordinating our response from a healthcare perspective right across the country. And under reporting into the National Incident Response Board was a number of what they call cells. And end of life was actually a named cell within that board, and I was the lead for that cell. So it was very clear from the beginning that end of life care was taken very seriously. By the way, when I say end of life care, I'm using that as a short form for meaning both palliative and end of life care. So it was a very clear part of that. What that meant was that because we were at the same virtual table with all the other cells, it also meant that we could hear what was going on in the other cells, and we could contribute to what was going on in the other cells and have a direct kind of involvement with them. And in particular, we had involvement with the medicines supply cell, the other supplies. So on the medicine supply, I should say, we actually looked at identifying a specific list of 10 medications that we absolutely must not run out of anywhere in the country. They became the top priority very early on. And then the medicines cell also continued to monitor 3 types of drugs: end of life, antibiotics, and critical care drugs. Those were the 3 sets that they monitored throughout the pandemic. We also had involvement with other supply cells, so syringe drivers, PPE, although, sorry, previous slide, please. PPE, and although we weren't the only ones dealing with that side of things. The other thing that we got involved in were the Nightingale hospitals. Now, I don't know whether you heard about the Nightingale hospitals, but these were big hospitals. So the one in London could have taken 4,000 beds, but there were Nightingale hospitals in different parts of the country, and they were being set up as an insurance policy. They were set up just in case the hospitals overflowed and we needed that overflow space. But the Nightingale hospitals were set up very quickly. They were often in places like warehouses and conference centres, so they were not built for healthcare. But one of the key things about the Nightingale hospitals was that we provided they needed to have a clinical assurance before they could kind of open, as it were, for work. And part of that clinical assurance included end-of-life care. So I was visiting all the Nightingale hospitals, checking their arrangements for end-of-life care, and making sure that they were suitable and they had thought about all the things. In fact, they were really good at thinking about it. But I think that might have been also because end-of-life care was definitely on the agenda for the Nightingale hospitals. It's something that not many people know or hear about, because obviously during the time of the pandemic, we didn't go around talking about it. We just got on with the job, really. So then there was testing and vaccination, and I don't think I need to go into that much more. But there was also hospital discharge. And then the other thing that we got involved in was around verification of death. So verification of death, which is not the same thing as certification of death. Verification is simply to say that the person has died. We had some special guidance for the pandemic period, whereby somebody who was not medically qualified or had nursing qualification to verify death could phone in and do that remotely with the guidance of a clinician at the central base. So that's the kind of guidance that we were writing. Now, at the moment, the National Incident Response Board has slightly evolved, and the end-of-life cell has now been hibernated. What that means is that I remain on standby to reactivate the cell within 7 days if needed. but otherwise we carry on with business as usual in palliative care nationally. So that was very much around what happened with end of life as part of the National Incident Response Board. Other things that we did nationally was that in England, hospices are funded, the voluntary sector hospices are funded partly by charity, partly by government. And obviously the charities struggled to fundraise during the pandemic period, and we managed to secure them several hundreds of millions of pounds for supporting the hospices to keep them going, and so that they could continue to provide capacity for palliative care and other patients as well. We wrote guidance, and that was a key part of what we did. These were national guidance around things like COVID, palliative care for people with COVID in hospitals. We looked at community. We looked at kind of medicines also. If you couldn't get hold of a syringe driver, how did you manage that sort of thing? Essential list of medication I've already talked about, so I'll skip past that. The security of other supplies that were relevant to palliative care I've also discussed. And then the last thing I've got on that slide is about communication, because it was really important that we kept that communication channel going. And so as soon as the pandemic started, I set up weekly calls, and they were 1-hour calls every week with clinical leaders in palliative care across the whole country. And we were fairly loose in who we regarded as clinical leaders. Basically, they were all the local leaders. They came to join the weekly call. It did two things. One was I could share any immediate information and guidance with them, very, really up-to-date information. But I also heard from them what was going on in different parts of the country. And that started a kind of a round of learning from each other very quickly. We separately set up weekly calls with our stakeholders. So these are a lot of the charities, particularly, who work with palliative care. And it was really important that they weren't left out of the conversation. So again, we had weekly calls with them, and we set up weekly webinars. And this was sort of for anybody who was interested in palliative care. Again, it provided a channel by which I could provide updates on a very regular basis, but also it meant that we could start inviting people to talk about their experience and to keep that shared learning going. In fact, the weekly webinars have continued, and then in about summer last year, we dropped them down to fortnightly, and we're now continuing to run them on a monthly basis because they have become a really important channel of communication. Next slide, please. So I thought I would just share with you some of the service response versus the experience. So these were, on the left-hand side, were what the different services did, palliative care services did, in order to prepare for the pandemic or in response to the pandemic. And then on the right-hand side, what their experience actually was. So hospital palliative care teams were already palliative care teams. Some had dedicated palliative care beds. Some developed dedicated palliative care beds for this. But they also experienced, what they actually experienced was severe pressure. They were the most visible of all the palliative care services because a lot of attention was placed on hospitals. They weren't always recognised for the great work that they did because, of course, hospital teams really were used to supporting people at the end of life, but they weren't used to the volume and the intensity. And also because of visiting restrictions, they weren't used to supporting patients where there were no families around. There were no families to talk to, and you had to do that remotely. In the community team very quickly moved to telemedicine, initially because they didn't have the PPE to be able to go and do home visits, but very soon after they started doing home visits again. But of course, patients were not always comfortable with them coming into the home because they didn't want health visitors potentially bringing COVID in. I think we'll need somebody to mute again, please. So on the community side, we then, as I said, patients were fearful of staff visiting. I think one of the consequences, one of our experiences, where there were less eyes on the patient, and particularly people who lived on their own. And we discovered after the lockdown was lifted that, patients had deteriorated much more than you could see through technology, or even through visiting, because their families weren't visiting, other staff weren't visiting, so there were less eyes on the patient, and complex needs went unrecognized or underreported. Day services, day hospices, attendance was suspended immediately, and then volunteer-led telephone response services started. And a lot of day services started developing virtual services, so blended offers, Zoom type of events, and coffee mornings, exercise classes on Zoom, that sort of thing. And actually, I think that's been quite a lesson learned for day services, is that virtual services were better received than expected. And there were some patients who might have been too ill to travel in for day services who could now participate because of the technology. And then hospices increased their capacity immediately. A lot, one of the hospices near to me, for example, went from 10 beds to preparing to take 26 people into the hospice. In fact, they never filled because actually there was in fact a drop in demand. People didn't want to come into hospices. And if they did, they wanted to get out quickly back to the safety of their homes. And hospices found that they also, unless they became a completely COVID-19 hospice, which really very little did, there were isolation areas that they needed to be built in, and it got quite complicated for them to manage that. So those were the service response. Next slide, please. And then on a more system level, what we found was that, first of all, systems did things, and by system I mean a whole local area, for example, cross-organizational boundaries. They set up things like single points of access. They did daily check-ins across the service. And what they found was single point of access does work. Now, in my own organization, because we have locally in Oxford, because we have an inpatient unit, we have hospital teams across 4 sites, we have a community team that goes out across the whole county, we have day services and so on, that what we did was we established a daily check-in. So for between 5 to 10 minutes at 10 to 9 every morning, we all dialed into a Teams meeting. And we just checked in across the service, checked how the workforce was, whether we need to move people around, any sickness and things like that. And actually, that is one of the habits we have now continued. So we still have daily check-ins, and they still only take 5 minutes, usually, sometimes 10 minutes. And so we've cultivated some good habits, I think, that we will continue. On the workforce itself, training at the height of the first wave of the pandemic, in fact, first and second wave, training and education was suspended. Things like appraisals were suspended. We moved to virtual meetings. Technology was brought in to support non-specialist areas. So very quickly we learned different ways of learning. A lot of free resources became available for education and training. We also learned different ways of working, and that had, I put down there, a psychological impact, both positive and negative, I think, the different ways of working. But also I expect, like you too, we experience a lot of need for self-isolation, and that includes people with young children. So as soon as their children were tested positive or were a contact of somebody tested positive, we lost staff. We also lost staff through sickness, both for short term, but also long COVID. And I still have a number of colleagues who are unable to return to full-time working. On the academia side, research activity was suspended, but on the other hand, on publication, publication became very free because, of course, the whole peer review process was suspended, and therefore we saw, and that's what I've described as kind of a bit of a publication bonanza, which I think we now have to review and kind of say, is everything at the kind of level of scrutiny that it should have had if we're going to act on it. Next slide, please. This is the result of a particular study called Cove Pal, which was run by King's College in London, where this was basically an online survey. They had almost 500 responses. Half of them were from UK, a quarter from Europe, and a quarter from the rest of the world. And the survey was run from April 2020 to July 2020. Obviously, that was sort of the end of our first wave here in England. And it identified some of the changes, and I think most of these I've already talked about, where services became more streamlined, they extended, they increased their outreach, technology was introduced, and staff well-being measures were put in. And one of the staff wellbeing measures, for example, that we did here, again in my local service, was that I had a weekly drop-in session where any staff could come with any concerns or any query, or simply just want to come and talk about how they're feeling. And that was a really important source of support for staff throughout that period. We also ran it online for staff who were working from home. Some of the enablers were described as being that the fear of an anxiety that kind of drove things forward, the duplication of effort to stop. Sorry, I've got that the wrong way around. Some of the barriers were fear and anxiety, the efforts being duplicated, although that got ironed out quite quickly, I think. That information overload that I talked about, some funding, although it depends on which area, because hospices, of course, did get significant extra funding to support them during that period. And a lot of NHS trusts did too. The things that helped were the willingness to collaborate very quickly, the fact that staff were very flexible. Now, this, remember I said, was part of the first wave. What we're seeing now is that flexibility has diminished because people are tired, they're burnt out, they're leaving, and so workforce is a much bigger issue now, I think, than in that period. Next slide, please. This is some qualitative comment that came through. As I said, the comment came through that palliative care services responded actively, but most felt ignored by national health systems. And I'll be really interested to hear your experience, both in Malaysia and other national health systems who are on the call, because I know we have a lot of international colleagues on the call with us. I don't actually think that in England, palliative care service was ignored. Palliative care service is underfunded and under-recognised in UK, like it is in many parts of the world, but I don't think it was particularly ignored during the pandemic. And I think part of the reason for that was because I had some very enlightened senior clinicians who were leading the whole pandemic response, who were determined that palliative and end-of-life care was part of the pandemic response, and that was incredibly helpful. So they talked about services providing expertise in symptom management and holistic care, and that the crucial role of palliative care must be better recognised and integrated, and I think that is certainly true. Next paragraph, please. Sorry, next slide, please. So just summarising some of the challenges, I think I was kind of thinking of them in terms of the different levels. So at the national level, at the macro level, one of the challenges was the balance between providing national guidance, which a lot of my colleagues were looking to me and to my team for in terms of having national guidance, but also how do you contextualize that locally? So what we say nationally has got to be much more generic than can be locally applied. So getting that balance right was important. The other challenge, but as I said, because of our involvement in the National Incident Response Board, was made easier, was around the challenges of supplies of medicines, syringe drivers, oxygen, PPE, etc. And then communication and guidance is what I call the Goldilocks effect. So having just enough communication, just enough guidance was important. Not too much, not too little, at the right time. That was what was important. And I'm not sure that we always got it right, but certainly that was something we were striving to achieve. And then at the middle level, in terms of the local organisation, local system, local provider of services, they were swamped trying to manage numbers. It was tended to focus on hospital beds, so out of hospital care, I think, suffered quite a lot during that period of time. And obviously at the individual level, there was always that tension between under-treatment as opposed to over-treatment. And as palliative care physicians, we found ourselves saying to our colleagues, just because somebody has got, a cancer or a condition that means they might die in 9-10 months down the line, doesn't mean that you shouldn't treat their COVID right now. So it was that kind of tension of saying to people, don't give up on palliative care patients. Don't regard them as dying just because they get COVID. So that was a really interesting dilemma to find ourselves in as a palliative care physician, where we're normally saying, please don't overtreat. The individual, the patient's anxieties about infection certainly often overrode their behavior to seek help. And that was a problem for us. And I think it was also a problem because our original slogan as a country was protect the NHS, and a lot of people took that literally and would not approach their GPs or palliative care services when they had problems that they needed help with. And we worked quite hard on things like treatment escalation plans to try and get that balance right. Next slide, please. A few more kind of random thoughts around this. So we have to think about adaptations, our immediate crisis response. We had to think about the provision by non-specialists in palliative care. How do we support and train them? How do we do the distance or remote working, and to what extent we might carry some of that on. Also, people needed to work outside their normal comfort zone. So for a lot of palliative care staff, we're used to face-to-face, hand-holding, touching, all the things that are tools of our trade. Suddenly we had to think about them differently. We had to manage that differently. And in the immediate crisis, we could drop all other activities. Everything stopped for COVID. But after the first wave, we're trying to be normal. We're trying to get back on track. We're trying to recover, but we still have a lot of backlog, and we still have a lot of patients who are sick with COVID, and we still have a lot of restrictions that we need to keep in place. So there's a lot of talk about new normal, but we don't really know what new normal looks like yet. And of course, there is an emotional cost to patients, to families, to staff, to public. The emotional cost of bereavement, the emotional cost of lockdown, the emotional cost of ongoing restrictions. Next paragraph, please. So some of the consequences of post-COVID or long COVID, I've already mentioned the psychological stress and the physical consequences of that. The delays to diagnosis and treatment that we're all facing right now. The need to highlight health inequalities, I think, is a really key part of this. And there's been a change to services and public attitudes. And in the National Health Service, it was really interesting, and this is a personal observation, that at the beginning of COVID, there was a lot of praise and a lot of appreciation of the National Health Service and the workforce in the NHS, to the extent that somebody started doing a clapping. I don't know whether you heard about this, but kind of people come out onto their doorsteps and they clapped for the NHS at something like 8 p.m. every Thursday evening. It was actually really difficult for many of us working in the NHS because we had a job, we had a secure job, we were doing our job, and to be clapped every week kind of felt a bit uncomfortable. That has obviously stopped now, but there's also been a shift in the sense that although quite a lot of the public are still very sympathetic towards the NHS, quite a lot of them are getting really impatient now that we can't go back to business as usual, they can't get back to normality, we can't break the waiting list, etc., etc. So there's a lot of balance that we need in society. We need to scrutinise. I think one of the consequences is we need to re-scrutinise the evidence that's been published and rethink and then incorporate new learning into what we do. So we've responded in a crisis mode, we've responded by compromising. We now need to think about whether those compromises are the right ones, but actually not just slide back into the old ways of doing either, because this has been a disruptive influence. We've got to think now about how do we capitalize on some of this? How do we hold on to innovations and replan them and reinvigorate them where that's necessary? And one of those areas, of course, is in digital technology. Next slide, please. And I read an interesting article recently about this false dichotomy between high tech and high touch, where, particularly in relation to palliative care, where there was a kind of a school of thought about high tech and a school of thought about no, we're a high touch palliative, we're a high touch kind of specialty. Actually, we can combine the two things and we don't need to be either one or the other. One of the things we found, for example, in my service is that we introduced very quickly virtual consultations using a platform called Attend Anywhere, but there's various other platforms, but the one we use was Attend Anywhere. And one of the things that is really good about Attend Anywhere is that during the consultation with the patient, so you send the patient a link, you go on it and you're having this virtual consultation, then at any point when you agree, you can bring in a relative of the patient who lives in a completely different part of the country, who can join the consultation, or you can bring in another professional who can join the consultation for that brief period that you need them for. And so there are advantages, and patients certainly, we've done a survey of patients who've either had or haven't had virtual consultations. And a lot of the ones who have had virtual consultations would quite like that to continue, not least because they don't have to travel to the hospital and they don't have to face the car parking problem that certainly we have in England, and I think many places have around hospitals. So there are these benefits to digital technology, and it can support more home-based care. It can support informal carers less intrusively. We just need to know that it is not everything, that it is an empowerment, an enhancement. It's not a barrier, but it's not a complete solution on its own either. And we also need to be careful, certainly in my part of the world, about digital exclusion, either because of people technologically or because there are parts of the country where the internet access is poorer, and therefore it keeps dropping, and if it keeps dropping, you have a poor quality consultation, and that is not fair on the patient. So looking forward, next slide please. Davis and Hayes have described this iceberg scenario of people thinking about, not just the complications of COVID infection, but the repercussions of the pandemic on people who did not have COVID, the workforce complications, and the general population living through. I've already referred to much of this as I went along, but those are things that I think in every country we've got to think through. How are we addressing this? Have we thought about it? Have we reflected and learned from it? And what do we do in preparation for the next pandemic? Next slide, please. And Downer et al. Has this, which you won't see in detail again when you see the slides, you can have a look at it, but actually there are things we've got to think of in terms of a pandemic plan for palliative care. There's the stockpiling of medication and equipment, and we're certainly looking at syringe drivers and making sure we've got enough syringe drivers. During the height of the pandemic, we did a deal with our critical care colleagues because the syringe drivers that were mobile we used in palliative care, whereas they used, where they would have used syringe drivers, they actually used equipment that was less mobile because their patients were less mobile. And so you can collaborate a lot with colleagues in that way. And then staff, I think a lot, again, having that expertise and also having the education and standardized support. One of the dilemmas that I'm personally finding is that on the one hand, I feel that as a national clinical director, I should be starting to plan for the next pandemic, but actually I have colleagues and staff who are exhausted and really need to recover before they can even begin to think of the next round of planning. In a pandemic plan, we need to think about space and we need to think about systems, and quite a lot of this, of course, we've now have experience of, and we should be building on that experience. Thank you. Next slide, please. I'm going to finish with a publication by the World Health Organization, which was actually about the pandemic, palliative care and human rights, and talking about the challenges for the human right to palliative care in the light of COVID, that there is significant new palliative care need. And of course, the other thing is we don't yet know what the natural history of long COVID is going to be. We don't know what palliative care needs long COVID may throw up, not just in terms of symptom management, but in terms of shortened life expectancy. We have just no idea at the moment. There are major challenges to palliative care for existing patients, and then that's continuing infection risk, resource limitations, and the need to continue providing psychosocial and spiritual care. So in their briefing note, they set out a set of recommendations. Next slide, please. And they talk about needing to frame national responses within a human rights perspective. So really keeping in mind the whole point about human rights and not losing sight of that. Making sure, and one of the challenges we had there, for example, was on visiting, and how do you square that if you have visiting restrictions which are about infection control, particularly in a hospital or an institutional setting like care homes, nursing homes, with the individual right of the person, so the right of the group versus the right of the individual. Making sure you've got basic services and medicines, we've already talked a lot about that, testing, treatment, making sure it's free of charge. Now, again, I'm very lucky in England because all treatments and all palliative care is free of charge. All testing is free of charge, but that is not necessarily the case everywhere. The recommendation includes allowing existing palliative care service to run. That is actually more difficult than it sounds because, of course, the same palliative care services are also delivering care to people with COVID, as we discovered. I think the rest of that is fairly self-explanatory, and I won't read through all of those recommendations, but I think they're really sensible recommendations and probably a good note on which to finish this talk and open up for discussion. Ednin, may I hand back to you, please?
Great, thanks very much. Yeah, I think that was quite a comprehensive discussion about the topic that we have in terms of looking at the role of palliative care within the COVID pandemic. I think that it does bring up, I think, lots of potential issues for discussions, and I'm really happy to open up questions and comments from anyone that's within the audience. So have a little think about some of the questions that you may want to pose. If you raise your hands, we'll try and see you, and we can allow you to unmute yourself and mute and maybe pose the questions. There are a few other people, I think, within the audience that I would certainly be happy to have some comments as well. So potentially maybe have a think about some of the things that you want to pose. But perhaps one of the things I would like to start off first be the way that the NHS has framed palliative care within a person-centered framework is somewhat unique, I think, towards the vast majority of nations that use national strategy, and that becomes a very much silo-driven aspect into what may be policy issues, what may be issues of access to medication services and other things. How do you think the aspects of the pandemic has affected the framework itself? Has it strengthened the way that the framework has worked, or has it created more tensions within a silo-driven facility?
I guess, Annie, I might need you to describe what you mean by silo-driven.
I think that in many countries they look at hospital services, they look at community services very much separately, and somewhere in the middle the patient gets left behind. Whereas I think that the person-centered framework, I think, puts the notion of the processes to follow the person rather than the effects of, say, hospitalization will inhibit patients getting care in hospital and disruptions to the coordination between hospitals and communities.
Yeah, okay, I see what you mean. I think there was already a move in the UK before the pandemic, in England, towards more integration. So the word integrated care has already been around for quite a few years. Quite what that means to the person, how that translates to the individual, we're still quite a long way from. So some people get brilliantly integrated care across hospitals and home and everything else, and quite a lot don't yet. The ambitions framework, I think, meant that we kept the focus on the person, but also on the system that needs in order to deliver it, because it was the first ambition was about person-centered care, but actually the other ambitions were about the systems being fair, being able to provide that individual care, all of those things. I think that during the pandemic, inevitably, the systems became more siloed anyway. There was a lot of focus on hospitals, and a lot of resources were in hospitals, ironically, of course, and of course that was partly because the sickest COVID patients ended up in hospital. So that was kind of where all the efforts got concentrated. And then as they started discharging people from hospital, that became a more obvious problem. And right now, the whole government is much more focused on thinking about what's needed in hospital. But somehow there is still a hospital-driven kind of tension that goes on. So I think the usefulness of something like the ambitions framework is simply that if we can persuade our colleagues in hospital, in the community, in the nursing homes, all to use it as their framework, at least they've got something similar that they're all holding on to, and that helps.
Thanks. Bee, within the Quality of Life Index, UK sits at the top of the pile. One of the thoughts I have is really in many countries around well, certainly around the region I know of, when the pandemic hit, palliative care was sometimes sidelined, may not be used very often. And one of my thoughts would be, how do you feel your colleagues in other areas of medicine view palliative care? They use palliative care as a resource to help in dealing with difficult questions, with advanced care planning issues, with symptom management in ICU, or how else would that work?
I think there's several things. If I leave the pandemic aside for the moment, I think the recognition of palliative care in the UK has been growing over decades anyway. The fact that it is a recognised specialty, I think certainly helps that enormously. So there is that recognition. So if you like, as a consultant, my respiratory consultant, my critical care consultant are my peers. They're no higher than I am, they're no lower than I am, they're peers. And that allows us to have that kind of voice, really. So that's one thing. So that's been going on for some time, and that's been growing. I think during the pandemic, it was actually very interesting because palliative care certainly in the hospital setting became very prominent during the pandemic. So at a time when people were being redeployed, so all sorts of staff were being redeployed, let's say from dermatology, even from oncology, into critical care, into respiratory. Palliative care was not. We had no, it was very clear, and we made the point that we cannot, if anything, we need people to be redeployed to us because we needed more manpower. And actually that happened in quite a lot of places. So in my own local service, we probably had about 4 or 5 extra people from oncology, from primary care, from pediatrics joining us to kind of boost up our resources for palliative care for a short period of time. So I think that was that. The interesting thing, though, my perception, and this is only my perception, is that as the pandemic is settling down at a more public level, we have a dichotomy. So we have people who say, the pandemic has made death and dying much more prominent, and we really must use this opportunity to drive forward, palliative care, da da da. We also have, on the other end, a denial, because it's almost like now that we're getting better at treating COVID and there's less COVID, that somehow people are not dying from COVID anymore. There's no death and dying anymore. So you almost have the other extreme. And it's a tension we have to try and manage. But at the moment, I am seeing that dichotomy in society, in the public, in the politicians, in everybody at all levels. Maybe not so much at the front line of healthcare. I think people have just got back to trying to do what they can. Oh. Certainly that's the UK experience and England experience anyway.
Right. The other question I would have is the experience of our patients with life-limiting disease, certainly in the community. I certainly do monitor the UK media, and I see sort of articles by palliative care people, by patients who are having sort of their end-of-life situations during lockdown, and the discussions around that. How do you look at the various ethical issues between the need for sort of end-of-life care for patients who may want to meet loved ones, and can't do that in the various isolation units around the country with COVID?
Yeah.
Now, how do you look at the ethical constructs of these situations?
It was really difficult, Etnin, and visiting was kind of probably the subject of more parliamentary questions and more sort of issues than anywhere else. It was really trying to, so there were different things we had to think about. The first thing was that balance between protecting the many versus the needs of the individual. The second thing was the location. So if you're in a major hospital like my hospice is on, we had a duty to reduce the footfall to the entire hospital site. And so we couldn't be exempt as a hospice sitting on an acute site from that, because otherwise we would be bringing that into the rest of the rest of the hospital. If you are a hospice on a standalone site, sitting on your own in lovely grounds around you, then you have only yourself to think about. Now you still have a group of patients to think about, but you have only yourself to think about. Again, in a setting where you had, now then of course there was the lockdown. So when there was a lockdown, from a law point of view, people couldn't move around anyway. So that kind of became a bit irrelevant during that period, because you just weren't allowed to move. So we couldn't allow visitors on that basis. It got really mucky once the lockdown was lifted, because in theory people could travel and come and see their loved ones, and we should be allowing that, but we have to find a safe way to do it. And so we tried various things locally. I suppose at a policy level, we're saying, find the safest way you can do it. So there were places that created rooms where patients could go into, there were barriers, there were all sorts of things they could do. And of course, in the first wave, we were hitting a really lovely weather period, so it was easy to do it outdoors. It really was not in the second wave. And then we had things like saying there were
Your voice has changed, Bee. Sorry about that.
Thank you. So then you had things like some places said if the person was dying, then you could allow a visitor or two, depending on ability to socially distance. That was kind of one of the policies at one stage. The problem was recognizing when somebody was dying. And are we talking about the last 24, 48 hours? Are we talking about the last week? Are we talking about last weeks? Some places would say, well, by definition, all palliative care patients are dying, so therefore all palliative care should be exempt. And then what we found locally was that if you said, look, you can have one visitor, one inevitably turned into two, two inevitably turned into three. And the people who bore the brunt of that were very often for inpatient units, it were the nurses, because they were the ones that were trying to manage that situation. And that was really hard. Now, if somebody's at home, that's a different matter, because once there was no law against visiting, that was for them to decide. It was their home.
I think that's quite interesting to look at. Your background, B, is general practice, and one of that's my really area of real interest. Yeah. And my question would be in the future development of palliative care within the public health, where the GPs and other really the vanguards that will determine access and aspects of palliative care. How did GPs deal with the situation of COVID, and what do you think would be the future of primary healthcare in the future in the UK?
Two big questions. I think how did they deal with the pandemic? I think admirably is what I would say. I think it was very hard for GPs because obviously their surgeries, they're physical spaces that have to be managed. And so they had to immediately do things like agree hot surgeries and cold surgeries. And there were all sorts of ways that were considered about how they could protect patients from infecting each other, basically. And also, obviously, primary care, like everywhere else, with the workforce situation, people getting sick, people having to self-isolate, meant that you always were running low on staff. And before COVID, we already knew that primary care was, again, we had a big deficit in GPs, basically, that we needed, and district nurses, and we didn't have enough, basically. So we already knew that before, and of course with the pandemic that kind of made things worse. I think they did very well during the pandemic, but there were areas where GPs simply could not visit, places like nursing homes, or there were places they could not visit, and they've not been forgiven for that. So that remains, and there is still a mantra that my GP won't visit or my district nurse won't visit, and actually it's no longer true, but people hold on to these things for much longer than is true. The future is hard to tell at the moment. I think there's a lot of very interesting plans for primary care. One of the things that might help them is there's been additional roles brought in. So, primary care is now organized into primary care networks. So they're still individual businesses, but they form kind of a network of primary care. And there have been additional roles that have been funded for those. So there's a pharmacy role, there's going to be AHP, allied health professional roles. There's something called social prescribers. So there's various roles that have been funded to support a PCN. The idea being some of these people can do some of the things that GPs used to do. That means that, that relieves the workload of the GP. Personally, I think one of the problems about that, I mean, it's great, but one of the problems about that is that you are asking GPs to work all the time at a much more intense level than when you had other, when you've got somebody coming in who you are directing to voluntary sector things, and where you've got lighter consultations, it's much more sustainable. If you're doing 10-minute consultation, every single consultation is only complex patients, that's really hard. And so I do worry about the sustainability of GPs and primary care, but there's a lot, I can't second guess what's going to happen in primary care other than they are going through a really rough time at the moment. And they are the backbone of vaccination, of course, that's the other thing.
I think we've got some potential comments, a question. Richard Lim, I think I saw your hand come up just now. Would you want to unmute yourself and pose your question or comment?
Hi, hello. Hi,
Richard.
hi, nice to see you again. Thank you very much for the talk. It was really interesting, and some of the things that you said actually really did actually resonate with us. I think our experiences, some were similar. Others, maybe there were, I would just say that in terms of our experience, we are still kind of, we are coming to the, well, I dare not say that it's the tail end, but we are seeing numbers coming down. There are our hospital, which was for a while a purely COVID hospital, so everything's on my ward actually was taken over. But things are slowly coming back, and I think one of the problems that we face, when I hear how you say that palliative care was one of the key areas that was emphasized right from the beginning of the pandemic, and I think that's just so it's so wonderful to hear, that there's so much vision over on your side. I felt like I'm trying to word this correctly because I'm concerned that this may be recorded somewhat, but some of the times I feel that for us, when we try to talk about the palliative care response to the pandemic, we tend to get certain other responses to that as though palliative care is somewhat a negative conversation, and it's not politically correct, and it's not popular with the leadership, and so then I think that in some ways it did get sidelined quite a bit. I did feel very concerned that there was a lot which was sometimes being missed, and we perhaps weren't able to get that much out. One thing that has actually I feel has come out of our experience is that, well, we did have that national policy and strategic plan launched just before the pandemic. Thank you very much, Vivi, for your guidance. And And I think that it has, I mean, it is a plan really to try and get palliative care available across the nation. We are still in a process of developing, but I think we have more people on the ground now gradually. And what it's possibly shown is, but I think the pandemic has actually kind of illustrated how important it is to have that network and have that service provided as a safety net. I think what we were seeing is that, you know, in places where we didn't have things so available, people really suffered the most. At least in some of our areas in the Klang Valley, we had some hospices and the community services still provided very essential kind of support to patients when they couldn't access hospitals. There were a lot of restrictions, definitely, and the movement control order. And there were challenges for the community to go out and see patients, but I think that at least there was something, and there was that a bit of a safety net, and I think that that's something that I feel I need to emphasize, you know, later on to the leadership, that we really need to do this to prepare for future kind of complications and pandemics and whatever may actually happen, you know, yeah. So yeah, that was our experience, and I just wanted, I mean, it's so nice that your leadership seems to actually recognize, and yet you said that you were under-recognized and underfunded.
Yeah, well, I know it's all relative. I do realize that. But it's interesting what you said, though, Richard, about the kind of it being seen as a negative, because that's the dichotomy I was saying to Edwin earlier on, I'm now seeing. So I have got a set of, you know, public leaders, politicians, or who are really, really interested in palliative care, perhaps as a result of the pandemic. But I also have another set who just do not want to talk about death and dying at all, who kind of deny that it's happening and so on. But you use the word safety net. I might pinch that word actually, because actually that's quite a useful way, maybe. You know, it's a way of people being able to say, yeah, we'll support this without feeling negative about it. That might be a good way to do it. I know we're more than safety nets, but even but that'll do if it gives us what we need.
Okay, I see two other comments. Can I just ask Dr. Faisal Mustafa? He is a consultant public health physician, and he's the deputy director of our NCD division in the Ministry of Health. He's been very supportive of palliative care. So certainly, Dr. Faisal, happy to have your comments.
Thank you very much, Anin, for acknowledging. Nice to meet you, Prof Bee. Hi, Richard. Long time no see. So I'll just share with you my comments, observations. I think for COVID-19 impact on the delivery of services across the NCD continuum, I think that's the first discussion that we need to talk about, especially palliative care in Malaysia. How COVID-19 has disrupted whatever minimal services we had available, and this is that pre-COVID-19 conversation. And when we talk about COVID-19 disruption, when WHO did their global survey, one of the most affected services is obviously rehabilitation and palliative care. I think that's the one thing. And what you have shared with us is more of the palliative care for COVID-19, which I think, Richard, you have to really talk to me about, because it's not something really visible in terms of, you know, when we had to make that difficult choices for COVID-19 patients that we choose not to put in ICUs for whatever reason. Do we see that as palliative care, or is that ignored completely across the various hospitals where COVID-19 patients are being treated? Because I think that's more relevant to what is being shared by Bee today. For me, I've had that conversation with other colleagues. And as a person who does not practice in the COVID-19 and who has been involved with policy, and I've not seen any policy or any guidelines on palliative care, as it were, for COVID-19 patients. Right? Let's just be clear on that, for COVID-19 patients when we make that difficult decision. So for maybe what you're telling me is something that I can't really relate when it comes to the work that we are doing with regards to the COVID-19 patients, as it were. Of course, you didn't touch much about how do we cope with the existing services. I think that's more a different conversation because of the different circumstances, as it were. But thank you very much. For me, this just reinforces this other conversation I had with other colleagues in public health. They were not palliative care people with public health who were working in other countries, looking at palliative care. The definition, even in Malaysia, you talk about palliative care, you only think about mostly cancer patients. It doesn't even extend to the general public, and perhaps more for the other healthcare professionals as well, rather than the other conditions, let alone COVID-19. So those are just my observations. But anyway, thank you very much for that. Perhaps Richard, maybe you can share COVID-19 and palliative care for COVID-19 patients, to educate me as well. Back to you, Annie.
Great, thanks, Dr. Faisal. Wonderful to have you here. Zini, Dr. Zini, Lim Zini, you have a question. You can unmute yourself and answer. Zini?
Hi.
Hi, Zini.
Hi, Prof Bee Wee, how are you?
Hiya. Good, thanks.
As you can see you. Well, I'm really envious of, in terms of the UK's response to the pandemic, how cohesive all the different sectors, are involved to provide care to this group of patients. I guess my question to you is, as a national clinical director, how do you coordinate and collaborate with the various hospices in the UK to support COVID positive patients who want to be looked after at home? Because in Malaysia, I think we certainly lack that coordination and collaboration, even though, working in a hospice where we want to support these patients, but there may be lack of infrastructure and lack of training to do so.
Okay, I think if I pick up on the training, first of all, of course, COVID-19, the palliative care for COVID-19 is new to us as well. So we were all learning as we went along, and there were things like, under management of breathlessness and then over management of breathlessness and all of those things, that just getting the level right, just in the same way as when we learn our palliative care skills, as Faisal has mentioned, we deal a lot with patients with cancer, but we also deal with patients with non-malignant disease. The transferability of what we know and understand is quite good, but not perfect. And so we have to learn to adapt to the situation. That's the first thing. How do I coordinate? I don't, because actually that level of coordination happens very locally. And really what we're saying is there were things we shared, for example, things like if you've got patients with, we don't have big teams. So I know we're bigger than what you have, but we don't have big teams. So if we're serving an area, then we can't have teams that are dedicated to palliative care for COVID patients only. It's the same service that serves all patients. And what we have to do as the leaders of those services is make sure that we look after everybody. We don't lose people on the way. But there are simple things like, if you are visiting somebody at home, then you do them last and you then disinfect after that. And, we very quickly would have worn PPE into every patient's home. It would be changed outside the patient's home and various kind of infection control maneuvers, which I'm sure you're all familiar with. But there would be things like actually looking after the COVID patients, you do your visits last. Or if you've got many COVID patients, then you do dedicated some of your staff that only look after COVID patients, that sort of thing. We are on different hospital sites here. So our hospital palliative care team on the site that was mainly taking COVID positive patients just stayed there. So they didn't come back to their offices, they didn't come to us, they just stayed on that site. And it was just a really kind of pretty basic infection control. For symptom management, it was doing what you did best. And then we tried to publish some guidelines. We published through the National Institute for Clinical Excellence some guidelines around managing symptoms for COVID. So that was really the main thing that we did in terms of letting people get on with their job. Just not forgetting that palliative care is palliative care, whatever you do. And we are the same service. So it was important that we try to apply that. The difference, I think, was sometimes in decision making about acutely ill COVID patients and the extent to which the question that Faisal raised earlier on, the extent to which things around decision making about whether they should be escalated to intensive care and so on. But we weren't the only ones making that decision. We were doing that with our colleagues who were really, you know, entrance into critical care is the domain of critical care colleagues. So the conversations we had with them was really more about saying, please don't write off patients just because they have got a life-limiting illness, and just bear that in mind in terms of how well the, you know, the usual ethical balance of benefit versus futility and so on. Does that help, Zinni? Does that answer your question?
Yes, yes, thank you.
Can I ask, I see Professor Anthony Cummings here. He's an old friend who used to be in Malaysia, but he's back in Ireland now.
Yeah, hi, Edmund. Hi, thank you. I actually met you before, Prof Bee Wee, when you came to Hospice to talk. My comment is about this. You talked about the planning for future pandemics, and doubtless there will be future pandemics, and the WHO guidelines. And the other thing you mentioned was about the central importance of GPs, the GP workforce. Now, one of the consequences from the pandemic, not just long COVID for patients and so on, but has been burnout for GPs.
Yeah.
And recently, like Ednan, I worked in the UK for many years, and I also keep up to date with UK politics and medicine and what have you. And what's happening most recently is patients and relatives are getting fed up with the continued lockdowns and intermittent lockdowns and so on, and things can't open up quickly enough. But they're taking this anger out on GPs. There's been a lot of instances of verbal violence and some physical violence.
Yes.
Now, the consequence of that has been that GPs who are now in their early 50s are taking early retirement. Younger doctors in hospital training are not going into general practice. How do you foresee how the UK would deal with a future pandemic with a very much reduced workforce, and a workforce maybe with reduced vigor or reduced energy because they're just beaten down by it? What are your thoughts about that?
Yeah, so if I'll come back to general practice specifically in a minute, I think that is the biggest dilemma that we have right now, certainly in the UK, but I suspect we're not the only ones having this dilemma. We do have a really, really exhausted, burnt out workforce. We already knew that our workforce was very thin, and more thin in some areas than others, before the pandemic ever hit, you know. Certainly in palliative care, I remember us having a workshop in early February about what are we going to do about the workforce issue sustainably. And of course, we haven't been able to act on the outcomes of that workshop since. I think GPs, as you say, have really borne the brunt of it. And of course, they are the ones delivering the vaccination. Without them, the vaccination program would not be where it is now. Regardless of what everybody else claims, it was primary care that was the backbone of the vaccination program that was so successful in the UK. How will we cope without a GP workforce? I honestly don't know. But Anthony, I'm afraid I'm also biased because I come from primary care. I deeply, deeply want primary care to survive. My own primary care colleagues are really very concerned about it, concerned, as you say, about the psychological impact, early retirements, people not wanting to come in, but also that whole idea of, can general practice as we know it be sustainable? Because if we're taking away some of the fun jobs, if you like, and your surgery list becomes really intense, can you sustain it? And that's probably true of a lot of specialties, actually. As we delegate more and more of the simpler tasks, it means that your intensity is much greater. So I honestly don't know, and I hope that the government, I don't know this, but I hope that the government recognises that without a primary care workforce, we would be in deep trouble. I think they sort of do. They don't quite know what to do about it yet.
Yes, I agree. I think that it sounds very gloomy at the moment, but let's be hopeful.
There are some superb leaders and who are really committed and really keen to try and improve things. Maybe one of the issues is we're trying to do everything at the same time. We're trying to recover, but we're being asked to recover you know, 150% as opposed to even trying to recover to 100% at a time when resources, both funding and staff, are really tight. And we're going to have to make some choices, I think, political choices in the country.
There's a big concern about, there's one last point, big concern about the sort of parking of NCD care and even cancer care. And so things like death rates are going up. People suffering, it seems, from what I read in the British media, seems to be increasing. And it is not to the politicians that they are venting their anger, but to the GPs.
Yeah,
and
that's right.
Unfortunate. That's unfortunate.
It's that redirection of anger is really, really unfortunate. I think the cancer's been relatively protected throughout the pandemic. The non-cancer conditions, I think, are the ones that have really suffered. The NCDs have really suffered. I think cancer's been protected.
Bee, I want to come into that question because Dr. Faisal is here and he's in charge of NCDs, and I see this as really potentially the biggest area that palliative care needs to be significantly involved with. But unfortunately, I think in Malaysia, the amount of non-cancer cases that we're seeing is such a small trickle that certainly within my referral rate, it's only 10% of non-cancer cases. And I think that this is really the biggest workload if you look at all the research of patients that need access to palliative care. How do you see that evolving over the years, not just in UK but elsewhere? Are we going to meet that need of dealing or putting palliative care front and center outside of just the cancer population?
I can only be hopeful and say yes, we will. I think that there's different approaches to it, isn't it? One is we have got to break that myth that palliative care is only for people with cancer, and that's in the public domain as well. So we have to try and move away from that. I think we need champions amongst our NCD colleagues. It's the only way to do it. So we need respiratory physicians, we need cardiologists who are saying palliative care is part of what we do, you know, of part of our patients' sort of journey, and we need to work together with them. I don't think we have great solutions in the UK either. It is more recognised, it is better, but you know, you get joint renal clinics in some places, you get joint heart failure clinics in a few other places. It's really patchy still, and it still depends on the palliative care interests of the local, if you like, NCD specialist and the NCD special interest of the palliative care physician before something like that happens. Yeah, I don't think there's an easy answer, but we are inching up. So our numbers are increasing, but we're nowhere near what we should be doing. And in our NHS long-term plan, there's big plans for cardiovascular disease, big plans for respiratory disease, you know, but they all stop short of acknowledging that people die. Even in the NHS long-term plan talks about living well with those conditions. It doesn't talk about them dying from those conditions, and we have to get past that.
Okay, thanks, Bee. I've got Su Ming with a question. Su Ming?
Hiya, you're on mute. You're still on mute, Su Ming.
Su Ming, you're still muted. Okay, now?
Okay, can you hear me?
Yes.
Sorry, muted for too long. Just to say hi, very quickly, I know we're kind of running short of time, and many in Malaysia, in this part of the world, probably going to, you know, preparing for dinner. But very quickly, I just wanted to refer to one of your earlier slides with regards to how, you know, the public health strategy for palliative care can be effective. And it must be incorporated by governments and owned by the community. And this is clearly something that, you know, I'm particularly interested in, because engagement of the community, engagement of civil society is something that I'm, you know, particularly, you know, that's something that I like to focus on. And then you talked about, you know, social empowerment through compassionate communities, community assets, and volunteer mobilization. Can I just ask you, in your experience in the UK, how much of the success of what you have seen with palliative care integration has seen it from the contribution of community mobilization, the engagement of volunteers, the engagement of civic society?
So I think at a local level, associated with organizations like hospices, the engagement of the volunteer community is massive. So if you think of hospices dotted around the country, and there are a lot of them, around them is a very strong community base and a very strong, and partly because they have to fundraise, so the community owns them in a very strong way. So in part, although there's always talk about why isn't the government funding all of the hospice and so on, actually because they have to fundraise, there is a kind of a mutual ownership with the community that's very, very powerful. So I think a lot of that success is at that level. I think that as a integration of palliative care into the wider healthcare kind of, the recognition of palliative care and so on as part of healthcare, I don't think that comes so much from the community at the moment. I think that comes more from the fact that it is a recognized specialty, and therefore you have to be accredited to work in the field and that sort of thing. So I think it comes at it from two sides. On the more healthcare front, it's more to do with it being a specialist area that is recognized as a specialty. And I'll come back to that in a sec, but the other, I think, is the hospice around it. One of the problems about, one of the things about the tensions we've been living with and trying to work with is that palliative care is a specialty, but was a little more siloed as a specialty. The end of life care strategy in England from 2008 was very much saying everybody's got a role to play in palliative care, which is great because that engages more people. But there's a risk then that people think you can deliver palliative care without any training. So there is that tension that we have to constantly manage. But that fundraising capacity is powerful.
And would you say in many ways also, perhaps also one of the challenges that Richard had voiced with regards to influencing society's perceptions about what palliative care is? Yeah,
I think it is the public can do a lot of that. I guess what maybe one of our influences also is that those hospices come together under big national umbrella bodies, and they're the ones who have the voice of the politicians and the policymakers. And sometimes my battle is to try and persuade our sort of leadership that that actually hospices are not the only deliverers of palliative care, that actually there is the whole of the healthcare sector and social care sector that's delivering palliative care, and we all do it in partnership. So sometimes one has to be careful about the balance of voices, of influences as well.
Thank you.
Bee, can I just ask you, what do you think is the role of standards and patient outcomes in terms of convincing sort of changing the narrative about palliative care? If we have better outcomes, better voices, that will change it away from the end of life situation into the quality of life and symptom management and improving care, the whole spectrum of life as it is, with the WHO resolution.
Yeah, I think it's a balance we're always going to have to battle with. I mean, I've discovered that one of the consequences of COVID at the moment for people who acknowledge that, that arm of people who acknowledge that death and dying is important, is there is an excessive focus on the death and dying bit at the moment, and trying to say, no, we've got to move further upstream is quite difficult. So I think that is going to be a difficult area to always manage that balance. Right. On the other hand, our long-term plan does focus on identifying people who are likely to be in their last year of life. So that helps to shift the balance a little bit.
I brought up the question because I think that certainly in our experience in Hospis Malaysia, the last 3 or 4 years have seen the duration of survival of our patients declining when they're being referred to us. 4 years ago, only about 20% of our patients were dying within a week, for example. But now the proportion of patients dying within a week has come up to nearly 40%. So referrals are actually getting later and later from our hospital colleagues, and that creates the perception that community palliative care is only for end-of-life care. And I think that changing that narrative is becoming more and more difficult. I'm just wondering how you would deal with that.
It's a really interesting point, Ednin, because before the pandemic, we have noticed that our referrals have been getting later. So that was a shift that we had spotted. And in fact, I think Mike Bennett published a paper on that not that long before the pandemic, that we were spotting that we were getting later referrals. Now, our interpretation of that locally was that because primary care was coming under more and more stress, that people simply didn't have time to stop and think about referring. Now, whether that's true or not, I don't know, but that was kind of our speculation when COVID hit and everything else went out the window. But we were certainly seeing that. How do we shift that? I think we have to shift that with the help of our colleagues outside of palliative care. I don't think we can do it on our own, because we can only, it's a bit like, you know, when you talk about, in the UK, we talk a lot about widening access to higher education. But you can only select from the people who turn up to be selected. And palliative care is the same. We've got to influence the people referring, or influence the demand through the public. Although that's Su Ming's question, wasn't it?
Yep. Right. I think we're coming to the end of the session.